Welcome to your deep dive. We're jumping into the source material you shared this time, some really useful revision notes. We're going to unpack it together.
Yeah, absolutely.
Our mission today, to take these notes on obstetric cholestasis, or ICP, as it's often called, intrahepatic cholestasis of pregnancy, and turn them into something really clear, really high yield for you.
Hmm.
We'll cover the basics, the risks, the management, basically everything you need from these notes.
And it's a topic that definitely deserves this focus. ICP, it's significant not just because of how uncomfortable it makes the mother, which can be really intense,
Right.
but also because of the potential risks it carries for the pregnancy itself. Managing it well is key.
Okay, so let's get straight into it. Based on the notes we have, what exactly is obstetric cholestasis, or ICP? What's the core definition?
So fundamentally, ICP is a liver disorder.
Hmm.
And crucially, it's one that happens during pregnancy.
Okay, pregnancy-specific liver issue.
Exactly. The core problem is that the normal flow of bile from the liver gets disrupted. It's impaired. And this leads to a buildup of bile acids in the mother's blood. These elevated bile acids are sort of the hallmark.
Got it. So liver's plumbing gets backed up, but only when pregnant.
That's the essence of it, yeah.
Yeah.
And these notes mention it affects around 1% of pregnancies here in the UK.
1%. Okay.
And even in the definition, it highlights a key risk straight away. It increases the chance of premature birth. Typically, you'll see it present in the third trimester.
With that itching everyone talks about?
Exactly. Intense itching, often without a rash, and those telltale elevated bile acids on blood tests.
Okay, so liver disorder, pregnancy only, bile flow issue, high bile acids, about 1% prevalence, shows up late, main symptom is itching. Why is it considered such a big deal beyond just being, another thing to worry about in pregnancy?
Well, the significance really comes down to the potential impact on the baby. Those bile acids, when they're high in the mother's blood, can cross the placenta.
Ah,
And that's where the risks come in. The notes list things like an increased risk of intrauterine death, stillbirth. Also, premature delivery, which we mentioned.
yeah.
Plus, meconium staining, that's the baby passing stool before birth, and fetal distress during labor.
Wow. Okay. Serious potential consequences.
Definitely. And for the mother, while the condition usually resolves after birth, that itching, it can be incredibly severe, debilitating even, affecting sleep, quality of life.
Yeah.
It's not trivial.
Oh, that sounds awful. Makes sense why it needs careful management. Now, what about the why? What do the notes say causes ICP? Is there one clear reason?
The short answer, according to this material, is no. The exact cause is actually unknown.
Really? Still unknown.
Yeah, it's not just one single factor. The notes point towards a combination of things likely playing a role.
Okay, like what sort of things?
They mention hormonal changes. Pregnancy hormones like estrogen are thought to be involved. Then there are genetic factors. It seems some people are just more predisposed.
Right, it runs in families sometimes.
Exactly. Family history is a risk
Yeah.
factor. And then they also list potential environmental factors, though it's less specific about what those might be. It's presented as this kind of complex interplay.
Okay, so no single smoking gun, hormones, genes, maybe environment, all mixing together somehow. If the cause is complex, does that mean some people are much more likely to get it? What are the specific risk factors listed in these notes?
Yes, definitely. And this is a really important section for revision. The notes list several key risk factors. Probably the biggest one is having a past history of ICP yourself.
Ah, if you've had it once.
You're much more likely to get it again. The notes give a recurrence rate between 45% and 90%. That's huge.
45 to 90%. Wow, that's definitely a key takeaway. If you've had it, you need to be watching for it next time. What else?
A family history, like we just touched on, particularly if your mother had ICP.
Mm.
Carrying a multiple pregnancy, so twins or triplets.
Okay.
Having gallstones already.
Yeah.
Infection with hepatitis C is listed.
Hmm.
And then certain ethnicities seem to have a higher predisposition.
Which ones do the notes mention?
They specifically point out people of South Asian and Scandinavian descent.
Interesting. So, previous ICP, family history, multiples, gallstones, hep C, or certain ethnic backgrounds, good list to keep in mind. That recurrence rate is really striking.
It really is.
Okay, let's dig a bit deeper into the pathophysiology. How does that impaired bile flow actually happen? What's going wrong inside the liver, according to the notes?
Right. So think about bile being made in the liver cells and then needing to be transported out into the bile ducts and eventually the gut.
Okay.
In ICP, the problem isn't usually like a physical blockage, say, from a gallstone blocking the main duct. It's more subtle than that. It seems to be an issue with the transport systems within the liver cells themselves, the pumps that move bile acids out.
So the pipes are okay, but the pumps aren't working right.
That's a good way to think about it, yeah. Something, probably related to those hormones or genetic factors, interferes with those transport mechanisms.
And then what happens?
Because the bile acids can't be efficiently pumped out, they start to accumulate inside the liver cells, and then they spill over into the bloodstream.
Leading to those elevated levels we test for.
Exactly. That's the central mechanism. The accumulation in the liver causes some liver dysfunction, and the high levels in the blood are what cause the main symptom, the itching, and also pose the risks to the baby.
Okay, that makes the connection really clear. Impaired pumps, bile acid backup, high levels in blood symptoms and risks.
Got it, Parsley.
Now, this sounds like a tricky diagnosis sometimes, especially with itching being common in pregnancy anyway. If someone presents with symptoms that could be ICP, how do doctors figure it out for sure? What other conditions mentioned in the notes might look similar? This feels like prime revision territory, the differential diagnosis.
It absolutely is. And the notes provide quite a list of things to consider, conditions that can cause either itching or abnormal liver tests in pregnancy or both.
What's on the list?
Okay, so you need to think about viral hepatitis like Hep A, B, C, or E, standard gallstones causing biliary issues. Then there are other major pregnancy complications like preeclampsia.
Which can affect the liver.
Right. And hyperemesis gravidarum, severe morning sickness, can sometimes cause liver enzyme changes.
Okay.
The notes also specifically list HELLP syndrome.
Yes. What does that stand for again?
That's hemolysis, red blood cell breakdown, elevated liver enzymes, and low platelet count. Another serious liver-related pregnancy condition.
Got it. HELLP. What else?
Acute fatty liver of pregnancy, which is
Right.
rare but very serious. Then you have potential chronic liver diseases that might just become apparent or worsen in pregnancy. Things like primary biliary cholangitis, autoimmune hepatitis, or Wilson's disease.
Wow, quite a few liver-specific things. What about conditions that just cause itching, not necessarily liver problems?
Good point. The notes include those too. There are other pregnancy-specific skin conditions that cause itching, like pemphigoid gestationis or PUPPP, pruritic urticariopapules, and plaques of pregnancy, though the notes here list prurigo in pregnancy and pruritus gravidarum specifically. And of course, you can just have regular atopic dermatitis, eczema, flaring up, or an allergic reaction.
So the key is sorting through all that.
Exactly. You use the specific pattern of symptoms, especially that characteristic itching on palms and soles, the timing alongside the investigations, particularly the bile acids and LFTs, to pinpoint ICP versus everything else. Distinguishing is crucial.
Definitely highlights the need for proper investigation. Okay, we mentioned the UK prevalence is around 1%. What about globally? Do the notes give a wider picture of the epidemiology?
They do. They give a global prevalence range of about 0.2% up to 2%, so quite a bit of variation worldwide.
And the UK fits in there.
Yeah, the UK figure of 0.7% to 1% is right in that ballpark. The notes reiterate that it's more common in those specific ethnic groups we mentioned earlier, South Asian and Scandinavian. And they again, link this variation to genetic susceptibility interacting with those reproductive hormones, especially estrogen, which fluctuate during pregnancy.
So overall, relatively uncommon, but not rare, with clear links to genetics and hormones driving who gets it and where it's more prevalent. Let's get back to the patient experience. What does someone with ICP actually feel? We know itching is key, but paint the full clinical picture based on the notes.
Okay, the absolute #1 symptom, the defining feature, is that intense itch and pruritus. And the really high-yield detail here, the thing to lock in for recall, is its typical location, palms of the hands and soles of the feet.
Palms and soles. Okay, that's the big clue.
It really is. Doesn't mean it can't be elsewhere, like the abdomen, but palms and soles are classic. Often there's no rash, just the intense urge to scratch.
What else might they notice?
Because of the bile flow disruption, they might report dark urine or pale light-colored stools. Some people develop jaundice, the yellowing of skin and eyes, but the notes say this is clinically obvious in only about 20% of cases.
Okay, so jaundice isn't always present.
No. Fatigue is also mentioned as an occasional symptom,
And when does this usually start?
typically late second or early third trimester. The notes specify mainly after the 30th week of gestation, and the itching is often described as being worse at night.
Oh, that must be miserable for sleep.
Absolutely. Significant sleep disturbance is common. The notes also mention less frequent symptoms like nausea, some loss of appetite, maybe some discomfort or pain in the upper right side of the abdomen where the liver is.
Any other signs a doctor might find?
Often, not much else on examination besides, scratch marks. An important point from the notes is that the itching, the pruritus, often starts before the blood tests become abnormal.
Ah, so the symptoms can come first.
Yes. And they also mentioned that because bile is needed to absorb fats, some people might experience fatty stool steatorrhea and potentially develop deficiencies in fat-soluble vitamins, like vitamin K.
Okay, clear picture. Intense palm salt itching, maybe dark urine pale stools, starts late pregnancy, often worse at night, sometimes nausea or RUQ pain, jaundice less common, and symptoms might precede the blood test changes. So how do you confirm the diagnosis definitively? What are the crucial investigations according to these notes?
Diagnosis really rests on that combination of the clinical picture,
Yeah.
especially the characteristic itch and specific blood tests.
Primarily liver tests.
Yes, liver function tests, LFTs, and most importantly, serum bile acid levels.
What's the absolute key test then?
The notes are very clear. The most sensitive and specific diagnostic marker for ICP is the total serum bile acid level. Measuring this is crucial.
And is there a specific level that confirms it?
Yes, the diagnostic cutoff given in the material is 10 micromoles per liter or higher.
10 or more. Got it. Is there a level that suggests it's more severe or carries higher risk?
There is. The notes associate levels over 40 micromoles per liter with more severe cholestasis and, importantly, a higher risk of adverse fetal outcomes.
Okay, 10 for diagnosis, 40 for higher risk. Good numbers to remember. Anything else about testing?
They recommend taking the blood sample when the patient is fasting, as bile acid levels can fluctuate after eating.
Right. And what about the standard LFTs, ALT, AST, ALP? What do they typically show?
So ALT, alanine transaminase, and AST, aspartate transaminase, are usually elevated, but typically only mildly. The notes say often not more than twice the upper limit of normal for pregnancy.
Only mild elevations, usually.
Often, yes. Alkaline phosphatase, or ALP, can also be elevated, sometimes quite significantly, maybe up to 4 times normal. But, and this is a really important point for revision, the notes state that ALP has limited diagnostic significance in ICP.
Why is that? Why isn't a high ALP that helpful here?
Because ALP levels naturally rise quite a bit during normal pregnancy anyway, especially later on as the placenta produces it. So a high ALP on its own doesn't really point specifically to ICP.
Ah, okay, that makes sense. Placental contribution confuses the picture. What about bilirubin?
Bilirubin might be elevated in about a quarter of cases, but usually not dramatically high, rarely over 6 milli-GDL according to the notes.
And you mentioned vitamin K earlier. Does that show up in tests?
It can indirectly. The notes mention that the prothrombin time, or PT, which measures blood clotting, can be prolonged. This happens if there's significant vitamin K deficiency due to fat malabsorption, but they do add that actual postpartum hemorrhage because of this is rare.
Okay, super clear on investigations. Fasting serum bile acids are key. 10 plus for diagnosis, 40 plus for high risk. All test often mildly up. ALP is less useful diagnostically due to pregnancy itself. PT might be up. Great summary.
Yeah.
So once you've diagnosed ICP, how is it managed? What's the approach outlined in these UK-focused notes?
The main goals of management, according to the notes, are twofold. First, provide relief for the mother's symptoms, especially that awful itching.
Yeah.
And second, try to prevent or minimize the potential complications for the baby.
Okay, how do they do that? What are the main strategies?
A big part of the discussion revolves around the timing of delivery. The notes mention considering induction of labor, often around 37 to 38 weeks gestation.
To reduce the risk of stillbirth later on?
That's the rationale, yes. However, it's really important to note that the material explicitly states the evidence supporting routine early induction for this purpose is uncertain.
Ah, okay, so it's not a definite must induce.
Not necessarily for everyone, no. The primary medical treatment mentioned is a medication called ursodeoxycholic acid, or UDCA.
UDCA, what does that do?
It's a type of bile acid itself, actually. It's thought to help improve bile flow, lower the levels of the more harmful bile acids in the blood, and often provide significant relief from the itching.
Does it help the baby's outcome too?
That's where the notes indicate some uncertainty again. While UDCA often improves the mother's symptoms and blood tests, the material suggests its effectiveness in definitely improving perinatal outcomes isn't clearly established from the evidence they reviewed.
Okay, so UDCA helps the mom, maybe helps the baby, but the evidence is debated. What else?
Vitamin K supplementation is mentioned, especially if there's evidence of fat malabsorption, like those fatty stools or a prolonged PT, to prevent bleeding issues. For the itching itself, Simple topical things like emollients or creams might be tried. But again, the notes say their effectiveness is uncertain.
Is there anything that should absolutely not be used? Anything contraindicated? This is always crucial for revision.
Yes, absolutely crucial. The notes are very clear on this. Avoid using dexamethasone.
Dexamethasone, the steroid. Why avoid that?
Because of concerns about potential adverse neurological effects on the fetus or the newborn. So that's a massive takeaway. UDCA is the mainstay treatment, but dexamethasone is a no-go.
Avoid dexamethasone. Got it. Loud and clear. What about monitoring during the pregnancy?
Regular monitoring is key. The notes recommend weekly checks of the liver function tests, LFTs.
Weekly LFTs.
Again,
Okay.
they suggest that if the LFTs either completely normalize or suddenly spike really high, you should perhaps reconsider the diagnosis. Maybe it was an ICP, or maybe something else is going on, like one of those differentials.
Makes sense. What about after the baby's born?
You need to check the LFTs again postpartum, but the notes advise waiting at least 10 days after delivery for things to settle before rechecking. Pregnancy itself really affects those levels.
Right. And going back to delivery timing, if the evidence for routine early induction isn't certain, how do clinicians balance that against the stillbirth risk, especially if bile acids are very high?
It's a definite clinical dilemma. The notes reflect this. They state there isn't clear data to support inducing everyone early just based on their biochemical results because those numbers don't perfectly predict stillbirth risk.
Okay.
However, they strongly advise considering induction of labor after 37 weeks, particularly in cases deemed severe.
And how do they define severe in this context?
Severe is defined in the notes as having both high transaminase levels, the all test on LFTs, and high bile acid levels, presumably over that 40 mark, though not explicitly stated again here.
So for the severe cases, induction is more strongly considered.
Yes. And they actually reference a specific RCOG Royal College of Obstetricians and Gynecologists guideline suggestion within the notes. Consider offering delivery at 37 weeks exactly, 37 plus euro, for pregnancies complicated by severe ICP. So it's a nuanced approach, risk stratified.
Okay, that clarifies it. Not routine for all, but definitely on the table, especially from 37 weeks if things look severe based on both LFTs and bile acids. What about the long-term outlook? What's the prognosis for mother and baby after it's all over?
For the mother, the prognosis is generally very good. Once the baby is delivered, the symptoms, especially the itching, usually resolve quite quickly, often within days.
And the liver tests go back to normal.
Yes, the LFT should normalize. The notes recommend checking them at the 6-week postpartum checkup to confirm this. If they haven't improved after 6 months, they suggest considering specialist referral.
What about the baby?
For the baby, assuming they navigated the pregnancy risks and were born safely, the long-term prognosis is generally excellent. The condition itself doesn't cause long-term problems for the baby after birth. The risks are all during the pregnancy.
Right, the preterm, birth, distress, stillbirth risks.
Exactly. The management is all about mitigating those in utero risks.
And we mentioned that very high recurrence rate.
Yes, absolutely crucial for counseling. That 45–90% risk of it happening again in future pregnancies needs to be discussed. It's highly likely to return.
Okay, so just to be absolutely explicit, let's list the main complications mentioned again. What are the potential adverse outcomes associated with ICP that management aims to prevent?
The key ones listed are preterm birth, spontaneous or induced, fetal distress during labor, and the most feared one, the increased risk of stillbirth, particularly later in gestation.
Any long-term risks for the mother mentioned?
The notes mention a slight potential increase in the risk of developing certain liver or biliary tract diseases later in life for the mother, but this seems less certain or common compared to the immediate pregnancy risks.
So primarily it's about managing those immediate risks to the baby during the pregnancy.
Precisely. That's why the close monitoring and the discussions around timing of delivery are so central to the management strategy. Timely intervention can really help reduce these risks.
Fantastic. Wow, we've really covered the key points from these notes. We've gone from that defining itch on the palms and soles through the diagnostic importance of bile acids, remembering those key levels, 10 and 40, the unknown cause but known risk factors, the whole list of differentials to consider. Right through to management with UDCA, that crucial point about avoiding dexamethasone and the careful considerations around delivery timing. You should now have a really solid, high-yield grasp of obstetric cholestasis based purely on this source material.
Yeah, to just quickly hammer home the absolute key takeaways for your revision. ICP is that liver disorder unique to pregnancy. It causes intense itching, often palms and soles, usually third trimester. Diagnosis hinges on serum bile acids. 10 or more confirms it. Over 40 means higher risk.
Right.
Management involves UDCA for symptoms, maybe vitamin K. Delivery timing needs careful consideration, especially induction from 37 weeks in severe cases. Absolutely avoid dexamethasone. And remember, it usually resolves fully for the mother after birth, but the recurrence rate is incredibly high.
Perfect summary.
And just to leave you with something to think about, given that the exact cause is still unknown, but the recurrence rate is so high and there are clear genetic links,
Yeah.
where do you think research should focus? Should it be on identifying specific genes to predict risk better? Or understanding those environmental triggers? Or maybe digging deeper into exactly how pregnancy hormones mess with those bile acid transporters in susceptible individuals? What's the next big question you'd want answered based on this info?
That's a brilliant question to mull over. Remember, this deep dive was tailored specifically for you, pulling out the essential, high-yield information from the revision notes you wanted to understand better. We really hope breaking it down like this helps lock it in for you.
Hopefully really useful.
And if you find this kind of breakdown helpful and you're looking for more resources, especially for exam preparation like the MSRA, the notes came from sources associated with passthemsra.com and freemsra.com, so you might want to check those out.
Good resources to know about.
Absolutely. Thank you so much for joining us for this deep dive into obstetric cholestasis. Keep exploring, keep learning.